giving the heads up when the timer's ready?
Yeah. Whenever you're ready.
Okay, good. Okay, so one of the main purposes of laws is to maintain social order and to protect individual citizens from outside aggression and harm. And this area of laws definitely applies to drug use and abuse because they cause severe social and individual harm. In 2002, drug abuse cost American society an estimated $181 billion. However, that number cannot fully represent the mental and physical harm that drug use and abuse brings. Drug users don't just harm themselves, they harm other individuals in their environment as well. Alcohol and drug abusing parents are 3 times likelier to abuse their children and 4 times likelier to neglect them than parents who do not abuse these substances. And it is believed that drug use plays a role in upwards of 70% of child abuse cases. Also, according to a study published in Traffic Injury Prevention, more than half of motor vehicle crash drivers tested positive for drugs other than alcohol in a level 1 trauma center. But drugs don't just harm other individuals, they also harm the individuals who take them. In 2006, there were 38,000 deaths from drug-induced causes and more than 1,750,000 emergency room visits for drug misuse and abuse. And legalization only leads to an increase in uses, and changing these laws and reducing regulation would only increase these detrimental and societal and personal costs. So drugs are negative and have dangerous effects, and while most people are not considering the legalization of drugs such as PCP, heroin, or methamphetamines, some drugs are being put forward for legalization, but these drugs are still dangerous to people in society. For example, MDMA has been put forward as a therapeutic treatment for anxiety disorders such as PTSD. However, MDMA has been found to have both acute adverse effects and long-term neurotoxic effects. MDMA has been linked to muscle breakdown, kidney failure, strokes, seizures, and heart attacks. And while this is often seen in high and serial dose cases, serious reactions and death have occurred after relatively low and single dose situations. PET scans and other neuroimaging studies in humans that are long-term users of MDMA show a reduction in serotonergic function. And these same long-term users show sleep problems, depressed mood, and memory and cognitive deficits. However, these are not just seen after chronic usage. In a study looking at squirrel monkeys, a single oral dose of MDMA caused significant dose-related depletions in serotonin molecules in multiple brain areas. And these effects were seen after 1 week of a single administration of the drug, and not even a very high concentration. It was a concentration lower than the average human dose of the drug. MDMA has also been shown to have significant abuse potential, and in a survey of ecstasy users, 43% met requirements for diagnostic criteria for dependence. And so, as I mentioned before, most people are not pushing for methamphetamine to be legalized. It's a very dangerous drug. Most people recognize that it has high abuse potential and can really be detrimental to individuals and the people around them. However, in a study directly comparing the behavioral and physiological effects of meth and MDMA, participants had difficulty distinguishing between the amphetamines. And these amphetamines have also both been shown to have very similar effects on social behavior. So, and studies in humans and animals have shown that MDMA and methamphetamine are both neurotoxic and they both have abuse potential. So why are we looking at MDMA for legality? It's just because it has a better reputation in the public eye. And also, our third point is, even if further research shows MDMA, validates MDMA's use as a therapeutic effect, it is unlikely that using pure MDMA would be the best option. Instead, we should use it as a jumping point for developing similar drug compounds that take advantage of those therapeutic effects while trying to limit the dangerous side effects and the abuse potential of these drugs. And once that drug had been produced, it would go under strict FDA clinical testing to ensure its safety and efficacy, and after its approval, it would be strictly regulated. This example can be seen in the modern drug of Marinol, which is THC isolate, the main active ingredient in marijuana. It's been used for the reduction of nausea in chemotherapy patients and also to increase appetite in HIV patients, both which are often put forward as a reasoning for medical marijuana, but Marinol does these same effects. It limits the active chemical to 1 instead of the over 200 found in marijuana that can have undesirable and potentially harmful effects, and it brings it into pill form, which gets rid of the health risks associated with smoking. So in conclusion, illegal drugs are harmful to individuals and to society as a whole and should remain illegal. And even if some drugs have therapeutic potential, we should take advantage of the pharmacology science that we have today to create new drug compounds that are safer and that can be evaluated and regulated through current FDA regulations. That's all I have.
Okay, first, I think you quoted a study that found that MDMA killed squirrel monkeys. You know?
No. It lowered serotonin levels.
Okay, lowered serotonin levels.
There have been MDMA deaths in human beings.
Okay. Well, there's a fun story about a study that was published in Science in 2002 or 2003, where a group at Johns Hopkins found some very, very bad effects of MDMA, but it turned out they had switched the labels on the vials, and they had given them meth in the dose that they thought was appropriate for MDMA, and that was what killed and caused great cognitive problems for the monkeys. So what I want to ask you is, in the human studies, how many of those were done with MDMA as opposed to ecstasy?
Okay, first I want to say one bad science study does not prove that anything, it says nothing about the effects or the problems with MDMA. There's been other studies, and we didn't quote that study because it was actually retracted later. Most of these studies are done with pure MDMA when you're doing laboratory testing with animals or with humans. The tests clearly from long-term users are going to be non-pure forms of the drug because that's what users are taking, but you can't regulate that.
So the chronic use situations where they've seen cognitive effects that are detrimental to people are in humans are coming from people who've used many other things and they have no control over it. Okay.
Okay. So the statement is basically saying that drugs are illegal to protect society, but there are drugs that are illegal currently that could have potential therapeutic effects, and the research needs to be done on that to determine if we can use those illegal compounds for improving patient life or for helping people. But the problem is the way drugs are scheduled can impact the research. And what I mean is, for example, marijuana is scheduled a Schedule 1 drug, which means that you cannot get NIH funding for Schedule 1 drugs. So the problem is the DEA has put this drug in Schedule 1 in the 70s when we really didn't understand how it worked and what it was really doing as far as medicinal purposes. We didn't find that out until much later. So, for example, you can use marijuana has been shown to improve people that have or help people with glaucoma and chronic pain, PTSD, anxiety. These are all problems that people have that are still the treatment options are still lacking, and they're still suffering. So there's potential therapeutic treatment there that's still illegal, and it's for us to get government funding for. So it can really so we need to we could possibly change the law to be able to increase the accessibility of certain drugs, to really look at how they can help people. But if you look at like Schedule 2 drugs, that includes cocaine and opiates, some of the drugs that are more harmful, you can get funding to do research on those from the NIH. But there's potential help there that we're not able to access currently. So if you want to get funding, you have to go through private foundations to do research in marijuana. And to do that, you have to get FDA approval. And it kind of creates this loop where it can kind of still prevent people from really pursuing that area of research, even currently, to figure out what certain drugs can really, or how certain drugs can actually help people. So, when talking about therapy, though, you have to consider a certain ratio that's popular in pharmacology, and that's the active dose, or the dose that would be used in therapy divided by the lethal dose. And then you can plot that against the dependency and see where drugs stand. And if you look at marijuana, it's the second lowest, meaning that there's no dose that can really kill people. You don't die from getting high off marijuana. And the dependency is extremely low. The only thing that's lower is LSD. But if you look at caffeine or alcohol, they're on the other end of the spectrum where they're much higher, they have a much higher dependency, but yet they're legal. So basically the statement's saying that none of the laws as is shouldn't change. But the problem is with that statement is there's potential to help people with certain compounds that are not available to patients. Could be if we could change the laws to increase funding for that type of research. And that's all I have to say.
So the person who spoke first,
That's me. You said something about their looking at their overdose potential, and that marijuana wasn't high on that list, but it's a Schedule I drug. But I mean, overdose potential is not the only dangers of a drug. Marijuana has been linked to increased schizophrenia rates and psychosis episodes. I mean, I don't think that you can only look at the dangers of a drug from overdose potential. What do you think? Sorry.
Am I allowed to comment on that?
Yeah, you can.
Okay. Well, I mean, there's. I'm not saying it would be right for everyone, or that there isn't other dangers, but even with drugs that we currently prescribe to patients, there's harm there. So it's always about how people treat that option. So if someone's just looking for marijuana to get high, then or versus a patient who comes in who has PTSD, none of the antipsychotic drugs have worked. 18% of veterans coming back from the war are suffering from PTSD, and there's a lack of treatment for them. So it's saying, yeah, maybe could cause some other psychological effects, but at the same time they have an underlying problem that's not being treated or addressed in the clinic currently. So it opens up a window for a potential option, and we all know that not every single person responds the same way to certain drugs like marijuana.
I know it's kind of cyclical because we don't know whether these drugs can be effective therapeutics because you can't get funding for them, but we don't know, and we do know that they have dangers associated with them, and we don't know what the therapeutic potential is. So why would you use these dangerous drugs in your studies when you could be using drugs that have been proven to be safer and look at their therapeutic potential, such as marijuana?
You said time?
Yes.
The current drug laws in this country were not made arbitrarily, but to protect individuals and society as a whole. MDMA was classified as Schedule I controlled substance in 1985, and now 27 years later, we still don't know enough about its psychopharmacology to safely remove it from that schedule. Our prompt for this debate was recent work which used MDMA in conjunction with psychotherapy to treat post-traumatic stress disorder patients. This most research into the possible pro-social effects of MDMA don't go so far as to suggest that MD may be used as the pharmaceutical for good reason. What is suggested is that MDMA is used as a tool to explore this complex behavior and how this system works. Research on potential pharmaceuticals should determine and refine the desired mechanisms so that when they are administered, its specificity negates neurotoxic and abuse potential. This study that we looked at was, that was our prompt, was conducted by Dr. Dobbins out of the MAPS organization, and it included 87% female. Only one patient in the study was suffering from war-related post-traumatic stress. MAPS would love for the applications of this study to be applicable to veterans, but the majority of veterans are male, and the research of the study was not into the effect of MDMA in assisting psychotherapy for war-related post-traumatic stress. There is a chance that male war veterans might not be as susceptible to this psychotherapy as female civilians. And why didn't this study look into the neuroimaging of these patients? PET and other neuroimaging studies in humans show a reduction in serotonergic function in heavy MDMA users. Why not ensure that these patients did not suffer neurotoxic damage, since animal research suggests that this is possible after a single administration? I also think that we also think that it's dangerous and irresponsible to take a population that's already at risk for substance abuse and give them an abused substance. What we have to accept is that even after legalization, we can't always control a substance. Prescription drug abuse is already a problem, so the idea that legalization would lead to less access to these drugs is false. In 2010, approximately 7 million US citizens were currently users of psychotherapeutic drugs that were not prescribed to them. That's 2% of the population. Prescription drug abuse is on the rise too, with 20% of teens saying they have taken prescription drugs without a doctor's prescription. Therefore, legalization does not mean more control or prevention, and increasing access to drugs such as MDMA for therapeutic reasons will lead to an increase in their availability to populations that will abuse them. Social costs are also high for nations who decide to take this legalization route. Legalization increases drug use and crime-related drug use, and nations in Europe are not necessarily benefiting from their legalization. The Netherlands, Amsterdam, has gained a reputation as a drug mecca of the Western world. Addicts are responsible for 80% of property damage, and the crime in the city necessitates that Amsterdam maintain a police presence far greater than those in cities comparable size. Drug violators account for 50% of the Dutch prison population, which is a higher proportion of that in the United States. And Amsterdam is currently in the process of shutting down numerous marijuana bars because of the nuisance that drug tourism causes. Danish laws have also always restricted the use of cocaine, LSD, psychedelic mushrooms, heroin, and MDMA. Our affirmative position in this debate, I feel, is stronger because it concerns the safety of citizens first and tempers rash decisions that lead to potential harm of those citizens. Thank you.
All right. So just kind of going back to the first part of your statement, you were mentioning about some of the neuroimaging and trying to figure out some of the neurotoxic effects.
I think that's particularly important when you're dealing with a population that's suffering from post-traumatic stress.
Let me finish. But what I'm trying to say is that, so you have these things that you're trying to figure out, but if funding is limited to the basic sciences, so not talking about the patient population, but just trying to figure out those basic mechanisms and understand them from a fundamental principle, how, it's trying to, where is the funding going to come from, and how can you better try to understand those, the basic principles before, going into a human population.
That's a good question. That's why we have animal research that is available for testing these mechanisms in mouse models and non-human primates.
Yeah, but do we not increase that by, say, just looking, so you were talking about MDMA, it's Schedule 1 right now. Well, as the statement's saying, laws shouldn't change. Well, if we changed that to a Schedule 2, that would open up for more available funds to better understand that, to then translate that into the clinic and maybe have a better understanding of the population, so maybe sex differences or whatever the issue may be. But
I think, can I respond?
No. I'm just kidding.
I think that current research in MDMA indicates that the neurotoxic effects should keep it at Schedule 1.
Yeah, but if there's still a lacking in the research and saying, okay, well maybe it works in some cases, not others, and it's not just, there's a multitude of drugs that we're talking about as well, not just DMA, but just the possibility to change the schedule of these drugs that we may have some therapeutic effect.
All right. Allow me to draw you a circle. No, I don't need to draw a circle. So the reason things are scheduled as Schedule 1 as opposed to let me clarify what Schedule 1 means. It means that NIH will not fund research on one of these drugs, and it means that doctors cannot prescribe these drugs. So Schedule 1 drugs include marijuana and ecstasy. Schedule 2 drugs can be prescribed by doctors, and it's generally easier to get anything lower than Schedule 1. It's generally easier to get funding to study them. These include things like cocaine, opium, morphine. LSD is Schedule 3 because it's not as harmful. Now, the reason something is put into Schedule 1, according to the DEA, according to the rules in the law, is that it has no legitimate medical use. And the way you determine whether something has a legitimate medical use is you go to the FDA and look, has this drug been approved to be marketed to people? Well, if it hasn't, then it has no legitimate medical use, and therefore it goes in Schedule 1. Well, how do you get it approved for marketing? You have to have funding to study it so that you can get it approved for marketing. But you don't have funding because it's in Schedule 1. When MDMA first came up for scheduling in 1984, the debate wasn't about whether it should be in Schedule 1 or Schedule 2. It was about whether it should be in Schedule 1 or Schedule 3, because it clearly didn't have the as dramatic effects as cocaine or other drugs we think of as particularly heinous. And the argument came before the judge, and all of the science was behind making it a Schedule 3 drug because it hadn't been studied yet thoroughly, but there was a thought that it had a chance to be a strong therapeutic drug, especially for use in psychotherapy sessions for patients with PTSD. And the way it works is, we talked in our neuroscience class this morning about how for psychotherapy to work, the patient needs to be very open with the psychiatrist and go through their fearful memories. So the reason, and the problem is, often they're not open. They're too afraid, they don't want to bring it up, they don't trust the psychotherapist. But this can be facilitated using ecstasy, MDMA, which helps facilitate trust. And using this just in their own testing, a fairly large group of psychiatrists had separately found that it was a useful tool in psychotherapy. So they told this judge, they're like, we think this would be a good thing to have studied, so we want you to put it not in Schedule 1 because we think people should be studying it. The judge then sent the recommendation Schedule 3 to the rest of the DEA, and the head was like, Schedule 1. This is the same thing that happened with marijuana. There have been several petitions which clearly like potential for abuse, and it clearly has medical uses, and it has a low potential for abuse compared to other more heinous drugs. And every time it goes up every time there's a petition, the judge says this should not be a Schedule I drug, but the judge is not in control. This is the DEA's administrative head judge, but there's a person above him who answers to political heads. So really, the problem is the laws are they're not based on science. They're not respecting science. It's going through sort of the political system, the political arena, and as scientists, we should be offended by this. It doesn't follow logic. It's laughably circular. And as a point, they were talking about how we should be studying MDMA in animals first, but you can't. What it's doing is facilitating psychotherapy, and I don't see how you can test the effectiveness of psychotherapy in animals. Also, the study that we were quoted, it took them many years. It took them until like 2002 to get the FDA to approve the study. He'd been trying for like 10 years. And then Jordan knows much more about this than I do. And finally, it was approved, and there were still roadblocks. Finally, they were able to do the research, and what they did was 2 8-hour sessions of psychotherapy. I believe it was double blind.
That's time.
Okay, I'll finish with your rebuttal.
Can the NSF fund these sorts of studies? Can the NSF fund, you described a circle where there's a lack of funding. Is it possible for the NSF to fund these studies?
In these situations, it tends to be clinical, like in human research, very translational things. And this isn't what the NSF is interested in funding.
Okay, but some of the basic mechanisms of drugs and their potential side effects and damage, I think, is something that the NSF could fund.
I think so.
And can you get funding from outside sources?
You can get funding from outside sources, but
Okay.
you have to, if you're going to use the drugs, you still need approval from agencies like the FDA, which are more politicized and can control you.
Okay, so it's not impossible. And I also wanted to point out that animals research, no one's trying to put a mouse on a couch here, but we're just looking for potential damage of these drugs because they can hurt biological systems. So, and I was wondering, how much more important is it to have a successful psychotherapy session to you than potential long-term damage?
So PTSD can be pretty severe. So possibly this is a situation like the lobotomy situation, where in the case of a severe epilepsy, it can be worth it.
Okay. Thank you.
Okay. So just to touch on what you were talking about, as far as the funding goes, that even if you could get NSF funding versus the NIH funding, I mean the NIH funding, is marginally small right now. The NSF is even smaller. So the funding availability is even smaller, smaller with NSF, even if it's possible, even if it was possible for you to get that funding. And not only if you could get funding, you have to get FDA approval for any Class 1 research or any Schedule 1 drug research. And then that's when you kind of can end up back in that loop. So even if that funding agency says, oh, here's the money, to do your research, well, you have to go back into the governmental system to even be able to perform that work. So then you can find yourself back in the vicious cycle. But just on the end of the rebuttal is, we're not saying that there are no harm with drugs and that every single drug should be street legal and available to anyone that could that wants that drug. But the statement is saying that the laws are protecting people, which we disagree with. That that the laws should be able to change if there's potential for compounds and substances and drugs to potentially help people. And to better understand that, we have to increase the availability to the research and to understand those principles. And then just kind of going back to what you were saying earlier about the cost for drugs, the harm, as far as in society, that there's a huge potential for regulations on drugs as far as taxation goes for the government. The harm in dealing with drug cartels and drug dealers and all of this can cause a huge problem for society. So if certain drugs do become legal eventually, then maybe some of that would be resolved and could be safer for people. That's all.
So for the second part, there's been a lot of indication that legalization does not lead to increased crime. Actually, lowering restrictions and lessening legalization on drugs actually is what leads to these massive increases in crime rate. And so legalization of these different drugs is not really a way to kind of lower those societal costs. But also, I was going to go back to your point that these drugs, these laws should be lessened so more research can be done. But these drugs are not stuck in Schedule 1 forever. The laws don't need to change for the drugs to move within the scheduling system. The laws can remain the same once it's been proven that these drugs are safe and that they have therapeutic potential. And it might be harder to get funding for these drugs, but it's because they've been shown to be dangerous in the past. And you can create these drugs like Marinol, where it's not a Schedule 1 drug the way that marijuana is. It's safer, it's easier to test, and you can then use that new compound that's in a lower schedule to look at the therapeutic effects of the main drug without as much danger to the participants. And you can also, these drugs are put into Schedule 1 for a reason that is not necessarily political, but is based on the dangers that they present to individuals in society. And if enough research comes out, then they can move down in a schedule. And I think that when a Schedule 1 drug